welcome to the new session of clinical pharmacology. And here we are speaking about the cardiovascular clinical pharmacology unit. We already covered diuretic, we covered the hypertension, heart failure, and now we are going to speak about angina and angina pectoris or angina pectoris. We are going to speak about the definition, types of angina, the pathophysiology of angina. Then we'll move to the drug therapy or pharmacological approach, non-pharmacological approach of drug therapy. Okay, so we will start with the anti-anginal drugs. As an introduction here, angina characterized by the sudden severe pressing chest pain radiating to the neck, jaw, back, and arms. And the angina normally is caused by insufficient coronary blood flow. So we don't have enough coronary blood flow. So we have insufficient coronary blood flow. The blood flow will be decreased, and as a result of the decreased blood flow, the result will be decreased oxygen supply to the heart, and this will lead to the insufficient to meet the oxygen demands of the myocardium. And for this reason, the cardiac muscle will suffer from ischemia, and therefore we call this one ischemic heart disease. And this one will be present as a clinical aspect with the chest pain that will last for about 15 seconds to the 15 minutes. In this case, we need to differentiate the ischemic heart disease and compare with the myocardial infarction. So ischemic heart disease kind of partial occlusion of the coronary arteries, partial occlusion of the coronary artery with the atherosclerosis. This is ischemic heart disease. So on the other hand, the patient will suffer with the angina. So what we have here, we have the thrombus, then we have the atherosclerosis, then we have the bleeding, we have the calcium, we have the atheroma, and this will lead to the complete occlusion of the arteries. So for this reason here, the patients suffer from cellular death or necrosis. So the situation with the myocardial infarction will be cellular death compared with the ischemia. So here, regarding the pathophysiology, as you can see, we have balance between the oxygen demands and oxygen supply. So we have this balance here in the heart. The oxygen supply, this one coming through the coronary blood flow. So the coronary blood flow supply the blood to the heart. That's great. And who's that determine how much blood flow do we need? The myocardium. So when the heart's increase work, when we have heart rate or increased contractility, that means we need more blood flow. We need coronary blood flow to maybe compensate. We need this one to increase to maybe to meet the need for the heart. So we need coronary blood flow to increase. So when you have increased heart rate, increased contractility, the result will be increased coronary blood flow through the coronary artery. So the situation here, coronary artery provide the blood flow to the heart. For this reason here, in healthy subject, we have a balance between oxygen demand and oxygen supply. You can see here when you have heart rate change or increased contractility, afterload and preload, all these, when we have positive activity on these function, the demand for oxygen will be increased, and the heart will or the coronary supply will be increased. So when you have increased demand, so our body will meet this one by increased supply through the coronary blood flow. So you can see here we have balance, and again between supply and the demand. So this balance is very important in order for the patient to live normal cardiovascular life. Okay, so this is the balance is very important, and you can see here we have several factors determine the oxygen supply and oxygen demand. For example, okay, so we have heart rate determine the oxygen demand. When you have increased heart rate, that means we need more oxygen. When you have increased contractility, that means we need more oxygen. When you have increased afterload or increased preload, and this one preload and afterload is like if you look on the heart muscles, preload and afterload. So for the preload and this is afterload, and this is a preload. Okay, so any increase in the preload and afterload, that will maybe lead to the increase of heart overload and increased demand of oxygen. So you can imagine here we need more oxygen, therefore the heart we are going to supply more oxygen to the heart muscles. So what happened there? This is maybe in the normal physiology function in healthy individuals. Okay, in healthy individuals we have this balance here between oxygen demand and oxygen supply. Moving to what we have, so when you have partial obstruction of the coronary arteries. So when you have partial obstruction of the coronary arteries, what happened here? Partial obstruction, that means the result will be decreased oxygen supply. You agree with me with this one here? Because the coronary artery is partially closed. The coronary artery is partially closed. So we are not going to have enough blood because of the partially close of the coronary arteries. So when you have this obstruction, partial obstruction of coronary blood flow, the result will be imbalance between the oxygen requirement and oxygen supply. So what happened there? We have the balance, and you can see now we have increased demand, we have increase in demand, and we have decreased supply. So increased demand and decreased supply, and the patient here suffers from ischemic heart disease. So you can see here here we are talking about the pathophysiology, what happened when you have partial obstruction of the coronary artery. You can see it there. Okay, so when you have partial obstruction of coronary artery, the result will lead to the imbalance between the oxygen supply and oxygen demands. So how we can treat the situation here? Now we can see the target. For example, we have heart rate, we can control heart rate, we can control contractility, we can control afterload or preload. All these could be target for us. Moving to another side, so we have coronary blood flow, we try to cause vasodilation in the coronary blood flow, or we are going to work on the endothelial cells. So I will start with the heart failure. We try to find some medication negatively decrease heart rate, reduces heart rate, reduce contractility. For example, here we have beta blocker, decrease heart rate and decrease contractility. We have verapamil, diltiazem, belong to the calcium channel blocker, decrease heart rate and contractility. That's great. On the other hand, speaking about preload and afterload, what we have here, they said, okay, the main medication for angina, organic nitrates or nitrates. Organic nitrates decrease preload and afterload. So we're going to discuss that in the next coming slide. On the other hand, for the coronary blood flow, we are going to speak about vasodilation, about antithrombotics and statins. So you can see here how many groups we have for patients from angina or angina. Beta blocker, calcium blocker, organic nitrate, and vasodilation, antithrombotic, statin. So all these options on the table. Okay, in clinical practice, we have three main types of angina or angina. We have stable angina, unstable angina. Stable angina, we call it stable angina or classic angina or typical angina. This is number one. And then we have the second one, unstable angina. And the third one, Prinzmetal or variant vasospastic angina. So as you can see here, we have three main types of angina. We have the stable, unstable, variant vasospastic angina. We have like a link to differentiate between stable and unstable angina. Okay, I'll bring this website to show you, maybe demonstrate what we have. Here we have stable angina or angina, and you can see that we have atherosclerosis, and it's like the arteries, the muscles. If you look on what we have here, the ventricle is healthy and benign, and you can see the atheroscleroma, and we have narrow the lumen of the coronary artery, but the patient is the normal outside of the exercise, and the AKG is normal. Moving to the patient with unstable angina, what we have here, the plaque will be ruptures and release the content. This will lead to the occlusion of the coronary artery. This stage is very close to the myocardial infarction. This is patient, it's considered like pre-myocardial infarction, unstable angina. So the unstable angina, we have like progressive disease and very risky. Okay, moving to the slide again there, what we have. So what we have here, we have three types of angina or angina. And then we have the link here if you need more information about these types of angina. Let us differentiate between these types of angina. So stable angina or classic typical angina, the most common form of angina, normally happen during the activity or exercise, running, walking, or climbing stairs. Normally relieved by rest. When the patient take rest, the pain will be dissolved, or when the patient take nitroglycerin sublingual under the tongue, the symptoms will be resolved. They said the symptoms occur when we have more than 75% of coronary artery suffer from stenosis, and normally caused by atherosclerosis. So the main cause for stable classic or typical angina will be atherosclerosis, and the artery will be closed like 75% will be closed by the atherosclerosis, and we have only 25% working on these arteries. On the AKG, we have ST segment depression as mild ischemia. Okay, so again, to summarize, stable angina or angina, stable angina, its most common form, and due to the atherosclerosis, relief by rest and nitroglycerin, the coronary artery closed by 75%, and we can see the ST segment depression on the AKG. Unstable angina is like unexpected chest pain. Anytime, could happen during rest or exercise. Unexpected chest pain usually occurs while resting. Classify between stable and MI. This is very risky. It's considered like medical emergency, because unstable angina, if left untreatment, the patient will suffer from myocardial infarction. The reason here, what happened? The patient suffer from platelet aggregation. We have platelet aggregation, we have thrombosis. Here we have clot. So this clot could be a closed coronary artery 100%. So this is what we have here in the unstable angina. Unexpected chest pain occur during rest. It's like classified between stable angina and myocardial infarction, and caused by platelet aggregation and coronary thrombosis. Okay, this type of angina, unstable angina, these symptoms are not relieved by rest or nitroglycerin, and the patient here should require hospital admission to the hospital for aggressive therapy. So we need to look on the patient other comorbidity, for example, lipidemia, diabetes, obesity. So we need to treat cardiovascular risk factors. If the patient has any risk factors, we need to start treat the patient from this risk factors such as lipid, obesity, hypertension, diabetes. All these risk factors should be addressed and treated. Okay. Regarding Prinzmetal variant vasospastic or rest angina, rest angina or vasospastic angina, uncommon form of the angina occur at rest. So we have two angina occur at rest. The unstable angina occur at rest. Prinzmetal vasospastic angina occur at rest. What happened here? The coronary arteries suffer from spasm. So we have spasm of coronary arteries. The most commonly happened in younger patients, The angina attack unrelated to the physical activity, as we mentioned, it could happen during rest. Spontaneously resolved within 20 minutes. Response to the coronary vasodilator, such as nitroglycerin and calcium channel blockers. So as you can see here, the medication for Brinsmetal or vasospastic or rest angina responds very well to the nitroglycerin and CCB. So the medication for the Brinsmetal or vasospastic angina, CCB, calcium channel blocker, and or nitroglycerin. Moving to the goal of therapy in patients with angina or stable angina include the goal of therapy, number one, relief symptoms, prevention or slowing disease progression, prevention future cardiac events such as MI and stable angina, and need for revascularizations. So here, if you left the patient without treatment, the patient will maybe progress towards the complication of the angina, such as MI and stable angina, and need for revascularization. So we need to improve symptoms, number one, slow progression of the disease, prevent further event, and improve survival, because we have risk of death. Okay. Non-pharmacological approach for the angina treatment, lifestyle modification, risk factor modification, smoking cessation. We encourage smoking cessation, angioplasty. This is non-pharmacological treatment, coronary artery bypass surgery. So we have several approaches: lifestyle modification, decreasing weight, control blood sugar, control blood pressure, treatment of hyperlipidemia with statin, modify risk factors such as smoking cessation, angioplasty. All these may be considered like non-pharmacological approach for the treatment of angina. What type of treatment available for the angina? We have four main groups for angina. We have nitrates. We have beta blockers. We have calcium channel blocker and sodium channel blocker. This medication could be used alone or combination. So we can use, for example, nitrate plus, for example, atenolol, or nitrate plus amlodipine. So we have the option to use a combination therapy between medication. Okay, anti-anginal drugs. Here we talk about a group: nitrate, calcium antagonist, beta blockers, ranolazine. Okay, regarding the nitrate, we have isosorbate dinitrate, then we have isosorbate mononitrate, we have nitroglycerin. Moving to the calcium antagonist, we have diltiazem, then we have verapamil. For beta blockers, we have atenolol, benderol, propranolol, metoprolol, and so on. We are going to discuss that in the next coming slide. And the last one, this is the fourth group, and the last medication is ranolazine. Ranolazine inhibits sodium channel during cardiac repolarization. So we have four group of medication used for heart failure. Okay, so nitrate, they have different volatility. So we have some maybe drugs solid at room temperature, such as isosorbate dinitrate, isosorbate mononitrate. Okay, let me show you the image or picture for this one. Here we have some picture for the isosorbate mononitrate. You can see the isosorbate mononitrate here, 20 milligram. And then we have another picture, for example, for, okay, this is isosorbate dinitrate. This is isosorbate dinitrate for the 20 milligram, for example. So we can see here We have several type of tablets. We have isosorbate dinitrate, isosorbate mononitrate available as tablet, and this is able to prescribe orally. Patient will swallow the tablet. Then we have nitroglycerin. Nitroglycerin. So for the nitroglycerin, okay, so I will maybe share with you. Nitroglycerin is coming like a small tablet, and we call nitroglycerin here like a pellet. Nitroglycerin. Okay, so I will share this screen with you about nitroglycerin, the small tablet here. So if I click on this website here, they will share with us. I will click on this image. I hope you can, okay, maximize. Now we are fine, and you can see nitroglycerin tablet. You can see here what we have, sublingual tablet. So this tablet placed under the tank, and this tablet start working after 2 to 3 minutes, and it's like a quick onset of action. Nitroglycerin, volatile. Then we have amyl nitrate, extremely volatile. This will come in like spray. So we have 3 types of nitrate: solid, volatile, and extremely volatile. These, when we use these compounds, cause rapid reduction in myocardial oxygen demands following rapid relief of symptoms. So when you prescribe it like under the tank, sublingual nitroglycerin, and this will start working from 1 to 2 minutes. The symptoms will be relieved. The symptom will be disappear in 2 to 3 minutes. So the rapid reduction in the oxygen demands, and followed by rapid relief of symptoms. Okay, so we're done with the first part. Okay, so in this image or picture here show the healthy blood vessels. So what we have here, we have healthy blood vessels. Okay, you can see here we have healthy blood vessels, and the healthy blood vessels that we have in the outer side, we have smooth muscle cells. This is smooth muscle cells, healthy smooth muscle cells. This is healthy individuals. On the inside, we have endothelial cells, ECS, endothelial cells. So we have 2 main components on the blood vessel. In the healthy blood vessel, we have 2 main components. Number 1, we have endothelial cells that lining the blood vessels, and surrounding the blood vessels, we have smooth muscle cells. So these 2 components work closely to maintain the function of blood vessels. So as you can see here, we have healthy endothelial cells. Then we have smooth muscle cells. Moving to the next slide. Here what they found in the study. In our body we have amino acid called arginine. Arginine will be converted to another compound called nitric oxide. Nitric oxide will leave the endothelial cells and move to the smooth cells. So you can see here the first step, conversion of arginine to the nitric oxide. Nitric oxide leave the endothelial cells and enter the smooth muscle cells. When the nitric oxide enters smooth muscle cells, will activate guanylate cyclase to the activation form of guanylate cyclase. Activation form of guanylate cyclase. This is kind of enzyme activation. Enzyme activation. So when you activate guanylate cyclase, this will lead to the conversion of guanosine triphosphate to the cyclic guanosine monophosphate. So this is the steps here, and we can type here plus. So the activation cyclic guanylate cyclase will activate conversion of GTP to the cyclic GMP. Okay, now how the nitrate work? We talk about nitrate will be, when you prescribe nitrate will be metabolized to the nitric oxide. Nitric oxide will activate guanylate cyclase. We discussed that this is enzyme, and this will lead to the increased cyclic GMP. Then the cyclic GMP will lead to the dephosphorylation of myosin light change. When you say dephosphorylation, here when we saw the dephosphorylation, that mean remove the phosphate from the myosin light change, and this will lead to the smooth muscle relaxation. And this is a key word for the nitric oxide. So nitric oxide, increased cyclic GMP, okay, dephosphorylation, and the end result will be relaxation. So we have the steps here. Okay, moving to the next. Okay, now we have the patient suffer from angina. We prescribe nitrate or nitrates to the patient. Nitrates taken orally or sublingual. Then will arrive to the blood. On the blood vessels, this is the blood vessels. This is represent the blood vessels. We already discussed that. We have smooth muscles. Then we have endothelial. We have smooth muscles here, endothelial cells here, and we have this under the microscope. So the arrive to the blood here, the blood vessels. You can see the blood vessels here. Okay, blood vessels leaving enter the endothelial cells, leave the endothelial cells, and enter the smooth muscles. So the nitrate enter smooth muscle. Nitrate convert to the nitric oxide. Nitric oxide will activate guanylate cyclase and enhance conversion of guanosine triphosphate to cyclic GMP. Cyclic GMP lead to the dephosphorylation, and you can see here the phosphate and our medication here, nitric oxide, remove the phosphate. Then we have myosin light change without phosphate, and this will lead to the relaxation. With the phosphate and interact with the actin, the result will be contraction. So we have two cases here. Phosphate will interact with the actin, the result will be contraction. When we have dephosphorylation, remove the phosphate, the result will be relaxation. Now we understand the mechanism, how the nitroglycerin. So we call this one nitroglycerin, and or other maybe textbook they call this one glycerin trinitrate. So we have two forms for the nitroglycerin, or two names. Okay, again we have another medication called Viagra or sildenafil. We are going to discuss that. They found Viagra or sildenafil inhibit enzyme called phosphodiesterase that will lead to the, when you inhibit this enzyme, this will lead to the prevent formation of guanylate monophosphate. For this reason, cyclic GMP will be increased, and this will lead to the dephosphorylation of myosin light change and relaxation. So in the beginning of Viagra introduced to the market, Viagra in the beginning introduced as anti-anginal drugs, but later on they found that Viagra is more effective in treated patients suffer from impotence or sexual dysfunction. Okay, so we're done with the mechanism of action, how the nitrate work in the human body. So we discussed the mechanism of action, the molecular mechanism of action, by saying that nitrates activate guanylate cyclase, nitrate work on the myosin light change, dephosphorylation of myosin light change cause vascular smooth muscle relaxation. And now this is the mechanism of action. This is here what we have here, we have action. So here we are talking about action, how the nitrate demonstrate their actions, nitrates. So what we have here, they said on the level of veins, what we have here, with a lower concentration of the medication, with a lower dose of nitrate, the result will be venodilation. That's great. On the artery level, if you need the effect to appear on artery level, we need high doses, we need higher concentration, and this will lead to the arterial dilation. So we have venodilation, arterial dilation. So we have two types of dilation. So we can say here, nitrate at lower doses cause venodilator, at higher doses cause both arterial dilation and venodilation. By increasing venous capacitance, this will lead to the decreased preload, and decrease cardiac output, and this will lead to the decreased oxygen demand. Hello everyone, and as the action of nitrate causes venodilator, that mean the diameters of the vein will increase, and you can see it like this one here, that we are going to have more blood remain in the vein and less blood come into the heart, and this will demonstrate by decreased preload. So decreasing preload due to the venodilator, and this will decrease heart overload and need for oxygen, and this will lead to the decreased oxygen demand. So what we have here, increased venous capacitance, decreased ventricular load, and this will lead to the decreased cardiac work, and the end result will be decreased oxygen consumption. Okay, speaking about arteries, this medication, nitrate, work on the coronary blood flow, Okay, what happened there? We have the atherosclerosis, coronary blood flow. Okay, what happened? So what happened there? This medication nitrate will increase or cause vasodilation. Okay, so the nitrate increase vasodilation, and this will lead to the increased blood supply. So we have two main mechanisms of action. Number one, decrease preload, number one. This will decrease oxygen consumption, and coronary blood flow will be increased, and we can call this one coronary vasodilation. This will lead to the increased blood supply or increased oxygen supply or decreased oxygen consumption. So nitrate work on two main mechanisms: venodilator, okay, and coronary blood flow vasodilation. Pharmacokinetic, nitroglycerin, when you apply it like a pellet under the tongue, the onset of action in about a minute or less, more or less. Isosorbate mononitrate, this is tablet, solid, if you remember, need 1 hour to see the effect. Okay, so you can see here for the nitroglycerin time for the onset of action, we need 1 hour for onset of action, 1 hour. But if you speak about nitroglycerin take 1 minute only to see the effect. So if the patient place the tablet under the tongue for nitroglycerin, they can see the action and relieve symptom of chest pain in this 1 minute. But if they have isosorbate dinitrate, 1 tablet, 2 tablets per day, this tablet need 1 hour. So for this reason here, we cannot use isosorbate dinitrate or mononitrate for quick relief symptoms, because this medication need 1 hour to start. And if the patients are from chest pain, we need some medication to start quickly. So which medication we are going to use to relieve symptom of chest pain quickly will be nitroglycerin. So this one should be placed under the tongue. Okay, sublingual, to see the effect quickly. Okay, nitroglycerin, we don't prescribe it oral or swallow with water, for example, because when you prescribe it orally, nitroglycerin will be destroyed, will be digestive, will be metabolized by something called first pass metabolism. Most of the medication will be metabolized in the GI system, mainly in the liver. So for this reason, the medication prescribed sublingually or transdermal patch, okay, to avoid elimination. So we can see here first pass metabolism working there. Isosorbate dinitrate, we have here dinitrate, mononitrate, both of them, the purpose, improved bioavailability, long duration of action, less hepatic breakdown. And this gives the warranty to the prescribe this medication orally. So this medication prescribed orally. So we have isosorbate dinitrate, isosorbate mononitrate. The purpose of this medication: improve bioavailability, improve duration of action, less hepatic breakdown. So we have mononitrate, then we have dinitrate. Okay, the table here summarizes the action of nitroglycerin. For example, You can see here the medication take, for example, 10 to 30 minute duration of action, but could be start in 1 minute. We have nitroglycerin sublingual example for short acting, long acting. We have dinitrate, we have mononitrate, and you can read the rest of this table at your own time. So we have duration of action, and you can see here they will remain around 4 to 6 hours, sometimes 10 hours. But the other medication for nitroglycerin remain the duration of action only minute to relieve symptoms. Adverse effect, speaking about adverse effect, all nitroglycerin cause headache, and around 35% of patients. So if you have 100 patients, 35%, about 35% will suffer from headache and flushing, facial flushing, tachycardia, postural hypotension, with the high doses of organic nitrate. So number one, headache, flushing, facial flushing, tachycardia. Some patients may suffer from postural hypotension. Now we have important maybe concept here. We need to maybe make the patient aware of this one. With the long-term treatment with the nitroglycerin, the patient will develop the tolerance towards the nitrate. Tolerance means that the blood vessels become less sensitive to the vasodilation. So with the chronic use of nitroglycerin or nitrate, the blood vessel will become less sensitive. And this explains the tolerance towards nitrate. This is the one concept. Another concept, we have Viagra or sildenafil. So Viagra and sildenafil work on similar mechanism. So they found, as you can see in the, if you go back to the graph, Viagra and sildenafil enhance action of nitrate. So I will go to the slide to maybe to refresh our mind. So you can see here, so you can see if the patient on the nitroglycerin, you prescribe nitroglycerin to your patient, and the nitroglycerin activate or enhance cyclic AMP, they said, wait a minute, Viagra will inhibit phosphodiesterase and enhance and increase activity of cyclic GMP. So they have something called additive effect. Okay, so what we have here, Viagra, sildenafil enhance the action of nitrate. Used with the nitrate, there's a risk of dangerous hypotension or like hypotensive crisis. Okay, how we can use it? For example, if the patient asks you to prescribe Viagra and he is on nitrate, so you can recommend the patient to take a 5 to 6 hour interval between the medication to avoid dangerous hypotension. So take the, for example, Viagra before sleeping, before go to the bed, but take the isorbit nitrate around 4 p.m. for example. Okay, so we already covered the nitrate and the information about nitrate, and patients suffer from angina or like myocardial ischemia, ischemic heart disease, and we discussed the nitrate. Moving to the second group of medication, we have beta adrenergic blockers. Blocking beta-1 receptor, this will lead to the blocking beta-1 receptor. So here we have beta-1 receptor. This will lead to the decreased cardiac output and the decreased blood pressure. So two things. Number one, decreased cardiac output. Number two, decreased blood pressure. This will lead to the decreased oxygen demand during exertion and at rest. So both of them will be great opportunities. Therefore, beta blocker could be you consider like one of the best medication for patients from stable angina. So by blocking beta-1, the result will be decreased cardiac output, decreased blood pressure, decreased oxygen demand. So this consequences here. As a refresh for our mind here, propranolol considered like prototype, the main medication in this group, but it's not cardioselective. So we're looking for something called the cardioselective, such as metoprolol or acebutolol or atenolol. So some medication considered like beta-1 selective. And again, they try to remind us with something else here important. What is talk about CI? CI stands for contraindications, not allowed to prescribe it, especially when you speak about non-selective beta blocker. Here we talk about propranolol. Propranolol, we don't recommend to use a non-selective beta blocker in patients with asthma. diabetes, severe bradycardia, peripheral vascular disease, chronic obstructive pulmonary disease. I'm not sure if this makes sense for you, but we need to understand why I don't recommend to use beta blocker, propranolol, non-selective beta blocker in patients with asthma, diabetes, severe bradycardia, peripheral vascular disease, and chronic obstructive pulmonary disease. Okay, I will maybe explain it when I finish with the last one here, what we have. They said if the patient on beta blockers, okay, with a long-term use, and you try to change the medication, and by stop the taking beta blocker, they said if you stop this medication suddenly, if you stop this medication abruptly, the patient may suffer from rebound angina or severe hypertension. Okay, they said if they stop this medication abruptly, the patient may suffer from rebound angina or severe hypertension. Therefore, don't discontinue. Don't stop this medication rapidly. We need to stop this medication gradually in order to keep this receptor active and bring this receptor to the activity again. So this one under the something called the upregulation, downregulation receptor. So when you block the receptor, what we have here, the situation will be when you block the receptor, the situation will be upregulation. That means we have increased number of the beta 1 receptor in the heart. Okay, this one, we left this one to the end to discuss it. We don't recommend to prescribe non-selective beta blocker to the patient with asthma, diabetes, bradycardia, peripheral artery disease, and chronic obstructive pulmonary disease. Maybe I need to go to the whiteboard. Okay, with the whiteboard here, we need to discuss something important. Okay. Okay, so what we have seen there, we discussed that with you. They said, okay, non-selective beta blockers is not recommended in patients with asthma. Not recommended in patients with peripheral artery disease. Not recommended with patients with diabetes mellitus, for example. So I will start, maybe I will explain at least two of them, why we don't recommend to use this medication in patients with why we don't recommend to use this medication in patients with asthma, peripheral artery disease, and diabetes. We try to explain. Okay, so what happened there? Speaking about the peripheral artery disease. Okay, so for the peripheral artery disease, this is a peripheral artery, this is blood vessels, and according to our information, we have the main receptor will be beta 2 receptor in the blood vessels and alpha 1 receptor, and we have kind of balance in the blood vessels between beta 2 and alpha 1. And according to your information in autonomic nervous system, you know that if you activate beta 1, the result will be vasodilation. And if you activate alpha 1, the result will be vasoconstriction. And we have balance, as you can see here, between beta 2 and alpha 1. Okay, so when you activate this receptor, that's great. So when you prescribe beta blocker to your patient, such as propranolol, so propranolol, block beta 1, and block beta 2. We know that beta 1 is mainly available in the heart, but beta 2, you can see beta 2 in the blood vessels. Okay, for this reason here, so propranolol block beta 2 in the heart. I will maybe scroll down a little bit. So propranolol block beta 2 in the heart. This one will be blocked. Okay, so now you can imagine here what we have. I will move this one. This one will be plugged. So this one kind of we already discussed that we have balance in the healthy subject. We have balance between alpha and beta 2, alpha 1, beta 2. If you block beta 2, okay, which one will be predominate when you block one of these receptors? If you block beta 2, the other receptor will be predominate. The other receptor will be the predominate will be alpha 1. If you like to remember the situation, I always try to represent that with a main river here. We have main river. Then we have two branches. Okay, this branch alpha 1 and other branch will be at beta 2. And your medication block beta 2 branch. What happened to the alpha 1? Will be enhanced flow, enhanced activation of alpha 1, and the result will be vasoconstriction. I will go back to the slide to discuss something with you. So what I said here, if the patient suffers from peripheral artery disease such as Raynaud's disease, we don't recommend to use this medication because this medication makes the situation worse. For asthma, similar situation will be applied. Okay. So what we have here in this table, we have some characteristic of beta blockers. This one could be important for the clinical practice. As you can see here, we discussed the medication name: propranolol, nadolol, sotalol, timolol. This is considered like non-selective, block beta 1, beta 2. This one selective beta 1 only: acebutolol, atenolol, bisoprolol, metoprolol, long-acting ismilol. Then we have another group of medication, block beta 1, beta 2. We have labetalol and carvedilol. Okay, so regarding this list here, or this table show us a group of medication. This table shows us a group of medication that are non-selective, block beta 1, beta 2, propranolol, nadolol, bindolol, sotalol. And then we have another group of medication considered like selective beta 1. We have atenolol, metoprolol, long-acting ismilol. Another group of medication, block beta 1, beta 2, and alpha 1. We have labetalol and carvedilol. So for alpha 1, for beta 1, beta 2, alpha 2, beta 1, beta 2, alpha 2, we have labetalol and carvedilol. Okay, so we covered the situation here, and we are familiar now with the beta adrenergic blocker for hypertension. Of course, we have another clinical use for beta blocker. It's not covered in this lecture today because we only discuss the angina, but we have other clinical use for beta blocker. Okay, for the third topic for the medication used for angina, calcium channel blocker, CCBs, calcium channel blocker. This is an important topic in angina. Okay, calcium channel blockers. Okay, as an important topic for us. So what we have here, we have calcium channel blocker, CCBs, essential for muscular contraction. Calcium channel blocker decrease smooth muscle tone. Okay, and decrease physical resistance. The result will be vasodilation. So CCB cause smooth muscle relaxation. CCB decrease myocardial contraction. CCB decrease contractility, decrease cardiac output, decrease contractility. Here we are talking about medication. We have two main groups of medication. We have dihydropyridine and non-dihydropyridine. We are to discuss it with you in maybe next slide. So what we have here, we need to remember how this medication works. We have two main medication here. Two main medication are repeated. The first group of medication mainly affect the blood vessels. Another group mainly affect the heart. So we have two groups of CCB. The first group affect the blood vessels. The second group affecting the heart, myocardium. For example, verapamil mainly affect the heart. Affect both, but mainly affect the heart. Verapamil affect blood vessels. and heart, but mainly affect the heart. So verapamil mainly affect the heart, nifadipine mainly affect the peripheral vasculature, nifadipine. Then we have diltiazem, intermediate action. So if you have this diagram here, and then we have here, we have heart, and here we have blood vessels. So let me go to the whiteboard again. Okay, so if you speak about system here, we have heart here. Then here we have blood vessels. And we are speaking about the calcium channel blockers. We have 3 medication. Okay, which medication mainly affect the heart? Verapamil. Okay, diltiazem. And then we have nifadipine. So now the question, which medication mainly affect the blood vessel? Nifadipine. Which medication mainly affect the heart? Verapamil. So verapamil block calcium channels on the heart. Nifadipine block calcium channels in the blood vessel. Okay, what about diltiazem? They said diltiazem, okay, diltiazem has intermediate action, work on both, intermediate action. So they put it in the middle because it affects both of them. Okay, good. So verapamil diltiazem mainly affect the heart, verapamil diltiazem, and for this reason we prefer to use these 2 medications for patients who are from AV node arrhythmias. So when the patients are from cardiac arrhythmia, especially for AV node arrhythmias, this will lead, maybe warrant the clinical use of verapamil and diltiazem. All CCB, all calcium channel blocker, lower blood pressure, but they worsen heart failure. So we don't prefer to use CCB in patients with a heart failure. This is a very important concept. CCB is considered like contraindication in patients with heart failure because CCB negatively maybe inhibit negatively affect the heart, inhibit the heart function, decrease contractility, decrease cardiac output. So we don't recommend to use it because this is the reason here. We don't so worsen heart failure. Why? The question here, why CCB worsen heart failure? Yes, because decrease contractility and decrease cardiac output. Okay. Next, we have the hydroperidine calcium channel blockers here. Here we are still speaking about the angina or angina pectoris. Amlodipine has minimal effect on the cardiac conduction and function mainly as arterial vasodilation. Amlodipine. So amlodipine is considered like long-acting medication. If you look on the amlodipine here, kind of the hydroperidine start onset of action 1 to 2 days and duration about 30 hours. It's remain for 30 hours duration of action. So this one is considered like once per day. Okay, so amlodipine minimal effect on cardiac conduction, mainly affect the arterial vasodilator. Amlodipine useful in the treatment of variant angina. If you remember, variant angina related to the spasm of coronary arteries, spontaneous spasm of the coronary artery. Amlodipine the treatment of choice. Nifadipine usually administered as extended release. Normally we prescribe nifadipine for patients suffer from angina, but we go the extended release. Short acting, okay, short acting dihydroperidine or like nifadipine should be avoided in patients with a coronary artery disease. I hope this will make sense. Nifadipine long acting amlodipine will be good for the heart, and we need to explain what happened there. Okay, so what we happened with short acting nifadipine, short acting SA, or we can call this one immediate release AR. So what happened with the immediate release? This medication mainly work on, we have the agreement, this medication mainly work on the blood vessels. Okay, cause vasodilation. Okay, the next will be when you have vasodilation, the result will be reflex tachycardia. Okay, when we speak about reflex tachycardia, that means this will be increased oxygen demands and increased risk of angina. The patient may suffer from increased risk of angina. So for this reason, we don't recommend to use nifadipine immediate release in patients suffer from angina due to the vasodilation, reflex tachycardia, increased demand of oxygen, and increased risk of angina episodes. Okay, so for this reason, we don't recommend it, should be avoided. It's very clear for us now. Okay, why we need to avoid short acting? We need to avoid, it's very important. Okay. Non-dehydropyridine, two medication, we have verapamil, then we have diltiazem. Verapamil slow AV conduction on the atrial ventricular node, decrease heart rate, decrease contractility, decrease blood pressure, decrease oxygen demands. All these belong to the verapamil. Verapamil mainly work on the heart, decrease or slow AV conduction, decrease heart rate, decrease blood pressure, decrease oxygen demands. That's great. Diltiazem also slow AV conduction, mainly work on the atrial ventricular conduction, and also cause coronary artery vasodilation. Okay, so diltiazem causes vasodilation. Diltiazem considered one of the best medication for patients from coronary artery spasm, and for this reason considered like the best medication for the angina. Variant angina, Brensmetal angina, because Brensmetal happened due to the coronary spasm. Brensmetal due to the coronary spasm. Therefore, diltiazem drug of choice. We don't prefer to prescribe any CCB for patients from heart failure again. Okay, this maybe a table here summarizes information for dehydropyridine, non-dehydropyridine. Dehydropyridine, we have nifadipine long-acting, amlodipine. For non-dehydropyridine, we have diltiazem controlled release, verapamil, and slow release verapamil. And then we have which medication mainly affect the peripheral blood vessels. You can see the nifadipine mainly affect blood vessels. If you look at the diltiazem, it's only one arrow. Verapamil is like intermediate between both, between heart and so nifadipine increase heart rate. You agree with this one? This one we call this one reflex tachycardia. Verapamil and diltiazem negatively affect the heart, decrease heart rate. So which of these calcium channel blocker increase heart rate? Nifadipine. What type of maybe mechanism the nifadipine increase heart rate? Reflex tachycardia, compensatory mechanism. Okay, the same slide repeated slide, but we have something important here. If you go to the slide here, give you the name, half-life, usual dose, side effect. Okay, we have this repeated information here for us, but this is new. For example, we can use nifadipine for patients suffer from stable angina, vasoactive angina, hypertension, Raynaud's syndrome or phenomenon, amlodipine, stable angina, vasoactive vasospastic angina, hypertension, for patients with a coronary artery disease, amlodipine, non-dehydropyridine, used for that. You can use it, very important, maybe clinical use, diltiazem, for patients suffer from atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia. Here we talk about cardiac arrhythmia. Cardiac arrhythmias, the medication we have very important medication work on the AV node, AV conduction, diltiazem and verapamil. It's like repeated in both, and diltiazem and verapamil to speak about supraventricular tachycardia and supraventricular paroxysmal tachycardia. So we're done with the calcium channel blockers. So we discussed with you nitrate or nitrates. We discussed with you the beta blockers. Then we have CCB, and we are moving to the last medication, ranolazine. Okay, nifadipine may cause flushing, a headache, hypotension, peripheral edema, peripheral edema. So we need to understand the situation here. Patient may suffer from constipations as a major problem here. Nifadipine, we explained the reflex tachycardia with you. Okay, so all these considered like side effects: flushing, headache, hypotension, peripheral edema. Okay, so nafadil being called reflex tachycardia and considered like contraindication in patient with angina. We don't prescribe this medication for patient with angina because the reflex tachycardia increases oxygen demands. This medication may cause constipations. We recommend patient to take a lot of fluid or take some laxative to treat the situation. Okay, I believe this is the last group or last drug used for angina, ranolazine, and the brand name Ranexa, available like 500 milligram, 1000 milligram, extended release tablets, Ranexa, ranolazine. How this medication work? They said this medication inhibit late phase of inward sodium current, INA, inhibit sodium channels, inhibit sodium current in the ischemic cardiac myocytes during cardiac repolarization. So main mechanism of action of ranolazine to inhibit the inward current sodium channels in the ischemic cardiac myocytes. And this will lead to the decreased contractility, decreased heart rate, and decreased oxygen demands. So decreased contractility, decreased heart rate, and decreased oxygen demand. For ranolazine, one of the medication used, ranolazine approved for angina as add-on therapy. What that means, the patient will be placed on nitrate, for example, and the patient still suffer from chest pain and symptoms. We can add beta blocker, but if the symptom remain, we can add ranolazine. Okay, so we have several options here. But what about the side effects, for example? They said ranolazine may increase or prolong QT interval. Ranolazine is not recommended to use it for the patient suffer from acute renal failure. They said it's required to discontinue this medication. So if the patient suffer from acute renal failure, we don't recommend to use it. And the last one, interaction. We have to be careful and read the information related to the interaction. So if you click on the link here, take you to the prescription information about Ranexa. Okay, maximize only a little bit to share with you what happened. Okay, this is Ranexa and the brand name Ranexa, generic name Ranolazine, and this medication considered like extended release and approved 2006, and this medication is considered like anti-anginal, indicated for the treatment of chronic angina, 500 milligram twice daily or 1000 milligram twice daily. I need to maybe focus on something important here. You can see the warning for the Ranexa. They said this medication may cause a QT interval prolongation. So this is an important maybe concept for the ranolazine, prolonged QT interval. What else? Speaking about the drug interaction, you can see here this medication metabolized by the cytochrome 3A4. And what that means, I will speak about one thing only. For example, here they said simvastatin 20 milligram. We need to limit simvastatin to 20. We don't allow to prescribe 40 or 80 milligram simvastatin because simvastatin uses a 3A4 cytochrome as substrate, and there's an interaction. If you go to the slide there, so what we have here, we have the medication information leaflet from the Access Data FDA. You can see it here, active data from the FDA, but at the same time they said, okay, is there any interaction between simvastatin and ranolazine? So what we can see here, according to the drugs.com, if you click on the link here, the link is not active, you need to click on the link. They said we have maybe drug interaction between simvastatin and ranolazine, and we need to adjust the dose for the medication. Okay, so we recommend you to review this on the drug.com. Okay, the slide here only to show you the patients are from angina, stable angina. So all patients should be given the following unless the contraindication. So now we have patients from angina. We prescribe aspirin. We can prescribe beta blockers such as atenolol. We prescribe angiotensin. We can prescribe statin. Okay, lowering LDL, sublingual nitroglycerin for immediate relief, calcium nitrate, long-acting, calcium antagonist, long-acting, calcium antagonist. Not all these medication, but all these medication on the table. So what we have, aspirin, beta blocker. So what I can type it there. Okay, aspirin, beta blocker, CCB. Okay, so we have other medication, the dibridamol, anxiolytic agent if needed, but this is the most important medication on the table for the patient. LDL, lowering medication, then we have ARBs, or instead of ARBs, angiotensin converting enzyme inhibitor. So all these group will be a candidate for treatment in patient with a heart, with a maybe ischemic heart disease or coronary artery disease. So I will go back again to show you a picture. Okay, this picture here from the website. Okay, I think it's coming from the research gate, and you can see here this picture here show us the type of angina we have it there. So we can see here the coronary spasm type of Prinzmetal angina or angina. What we have here, we have coronary microvascular dysfunction, and they told us what type of medication we are going to use. For example, when you have coronary spasm, they said CCB or nicorandil or long-acting. So coronary spasm. For when you have like unstable angina, you can see the atherosclerosis there. Then we have a group of medication. What about the patient who suffer from coronary microvascular dysfunction? We have a less of medication. Okay, so you can see here for the occlusive artery atherosclerosis, classic angina, we have beta blockers, we have non-dehydropiridine, ivabradine, ranolazine. So we have a group of medication could be used there. Another group of medication, maybe the question now, what type of guidelines we are going to use? So this one here with a published article published in American Journal American of College Cardiology 2023. I like what we have here. They start speaking about the patients from angina, how to approach the patient, what type of medication we are going to use. I hope you can read it at your own time, but it's very interesting and new updated how to approach patient with the angina according to the guidelines. Okay, so what we cover in our lecture here, we cover the nitrate, amine nitrate, isosorbate dinitrate, isosorbate mononitrate, nitroglycerin, topical like spray. We discussed calcium channel blocker, amlodipine, deltazim, phenoldipan, nicardipine, nifadipine, nimodipine, ranolazine as a metabolism modifier. We done with the angina. Okay, so let us recap what we have discussed in our lecture today. We start with the anti-anginal drugs. We have the introduction, discuss the definition of angina as sudden severe chest pain radiate to the neck, jaw, and arm. Then we discuss the pathophysiology regarding the oxygen supply and oxygen demand. We discuss the balance between these demand and supply and what factors may aggravate the situation. And then we discuss the partial occlusion of the coronary arteries. We differentiate between three types of angina, such as stable angina or angina, unstable angina, Prinzmetal or vasospastic angina. Then we move to the goal of therapy. We discuss the goal of therapy to relieve symptoms, decrease the progression of the disease, prevent future cardiac event, improve survival, all these goal therapy. We discuss a non-pharmacological approach for the patient, Then we moved through the pharmacological approach, and we spoke about 4 main medication that include nitrate, beta blockers, calcium channel blockers, and sodium blockers. Okay, we differentiate between the pharmacokinetic, pharmacodynamic of each group. Then we demonstrate the guidelines according to the 2023 how to approach patients from angina according to the American guidelines. I hope you enjoy this lectures, and thanks so much and have a great day.